Hey, my name is Gwendolyn Roundtree, and today I'm going to be talking about primary congenital hypothyroidism. So what is primary congenital hypothyroidism? It's a genetic disorder that results in inhibition of proper function of the thyroid gland. So hypo, it means underreactive, and thyroid, so it means an underreactive thyroid. So this means that it does not function properly and it does not put out the amount of hormones that it needs to. So as we can see, the role of the thyroid is hormone production that stimulates growth, brain development, and metabolism. So if we have an underactive thyroid, that means that we aren't going to be producing these hormones that are going to stimulate our growth, brain development, and metabolism, and these things are going to be stunted. So here in this picture we can see a thyroid gland in the human, and we can see that that is just between, it's in our throat, just between our chin and our sternum. So you can actually palpate that on yourself, which is very interesting. So this condition is prevalent in about 1 in every 3,000 newborns. And the effects of this condition, they appear within 3 to 4 weeks of birth, and babies can experience jaundice, constipation, swelling, extended stomach, delayed growth, delayed learning, and weak muscle tone. Now, maybe some of these conditions could happen together, but it doesn't necessarily mean that all of these symptoms have to present themselves for this condition to be there. So, genetic inheritance. So we talked about that this is a genetically inherited disorder. So let's look at the genes that are responsible for that. So we have our PAX8 gene and our TSHR gene, and these encode for proper growth and development of the thyroid gland. So when we have a mutation in these genes, that means that our thyroid gland is not going to be developed the way that it properly should. So sometimes that means that it can be underdeveloped, so it can be a smaller thyroid gland, or there can be portions of it that did not develop. So our autosomal recessive inheritance pattern, that's going to be how this disorder is inherited. So it's going to be on our autosomes, which means that it's not on our sex genes, so it's not going to be like passed down from like a father to a daughter or father to a son or anything like that. So recessive means that you have to have 2 recessive alleles in order to have the physical expression of this gene. You can't be a carrier and physically express this gene. So in order to create an affected offspring, both parents need to be carriers of the gene but don't show any physical expression, or at least one parent be affected by the gene and one parent be a carrier. And we can actually look at that a little bit further here. So hypothetically, let's just say that our affected individual has 2 recessive alleles here, and that will be designated by the small a, small a. Our carrier is going to be large A, little a, and our non-affected individual is going to have 2 dominant alleles with the uppercase A. So here, in this instance, we have 2 carriers because they have 1 dominant and 1 recessive allele. And we can see here, in this instance, they actually created an offspring that is an affected individual. And we see of the 4 offspring, that's about a 25% chance of occurring between 2 carriers. Now, over here we can see this is 2 non-affected individuals, but one happens to be a carrier. But none of their offspring will have the trait because one parent has the 2 dominant alleles, and that's always going to overcome that recessive allele. Now, if we have the carrier and the affected individual, like I was talking about earlier, we see that we have about a 50% chance of having an affected offspring. So we have 2 small a's, 2 small a's, and then 2 carriers. So in our inheritance pattern here, we can see this is going to designate the small green, that's going to designate an affected individual. So they're going to physically express the traits of this gene. So here we have Linda. She's an affected individual and she marries a carrier. And then they happen to have a son who is also a carrier. Now we can go over to Walter and Diana, which they are different because this is two carriers that are having a child that's a carrier. And then when Susan and Jason have offspring, we see that they actually, since they are both carriers, they have two offspring that are affected individuals, and then one offspring that is not affected at all. And then, so we see Molly here, she's an affected individual who marries a non-affected individual, and they have two carriers. And then Ryan and Jamie, an affected individual and a carrier, they're going to have one affected individual and then two carriers. So that's a little more detail on the inheritance pattern here with our pedigree chart that kind of puts that into perspective on how this can be passed down between generations. So genetics of the PAX8 mutation. So the PAX8 mutation is the mutation that's most frequently seen in individuals with primary congenital hypothyroidism, and this is a point mutation, and it prevents the transcription factor from binding to DNA. So that means that it cannot regulate genes because it cannot bind to the DNA. So it can't regulate those genes that are supposed to encode for proper thyroid development because it can't bind to the DNA at all. So this is where we get mutations that result in either the small thyroid or the portions of it that don't develop at all. So what does the treatment look like for primary congenital hypothyroidism? So most often we see oral pharmaceuticals. Most common one used is levothyroxine, and it replaces the missing thyroid hormone to restore proper levels of TSH and T4. So when our thyroid isn't developed properly, our thyroid stimulating hormone is going to be high because it's trying to get that thyroid to work. So it's putting out all of this thyroid stimulating hormone, but because that thyroid is not working. And then our T4 levels are going to be low because that's a hormone that our thyroid puts out. Now these oral pharmaceuticals, these are required for life because this condition does not go away. Alright, so genetic testing for this disorder. So we talked about how it can be inherited. Now, how do we find out if we have it or not? So newborn screenings are the most common method of testing for this. In the United States, all 50 states require these newborn screenings. So the only time you would see someone who did not have this screening or a test for this disease is if you're in like a third world country or something like that. So one test is the Baby Genes Targeted Panel, and the method is a heel stick. So they draw blood from the baby's heel just after they're born. And so why is it required in all 50 states? So it's required because appropriate measures can be taken to prevent irreversible developmental damage. So we talked about how those babies can have brain damage, their metabolism can be stunted. So it's really important that you have a diagnosis early so that those oral pharmaceuticals can be put in place to help prevent any irreversible damage in their development. However, some controversy does exist as to which test that it's coupled with. So, meaning that when the baby gets the heel stick, they're also tested for several other disorders. And so there's controversy over whether or not some of these disorders have appropriate treatments and whether or not you should be able to know if you have that condition if there's not a treatment available. So when is genetic testing performed? So this is between 2 to 4 days of age, and most often it's prior to them leaving the hospital. So they shouldn't leave the hospital until they have this test done. And so where do we do it? We do it at the hospital right after our baby's born. And how expensive is it? It just depends on your geographical area. So it's approximately between $15 to $150 depending on where you live. So a prognosis. So this is a permanent condition, so it's not going to go away, but early detection is vital. So early detection leads to prevention of permanent developmental delays, most significantly in the brain. So if we detect this early, we can treat it, and then we don't have to worry about those that irreversible brain damage. So the condition is treatable with oral meds, but the TSH and T4 levels should be continuously monitored through routine blood work. So this is something that the individual is going to have to follow up with their primary care provider for the rest of their life just to manage those levels. And the disorder can be passed down to future generations. So overall, unfortunately, it is a disorder that can be passed down, can't be stopped, but it is a disorder that's very treatable and very manageable. So we've come a long way. And then these are all of my references. I'd like to thank for all of the information that I've given you thus far.